All right, so today's topic, I mean, we're so fortunate that we have 3 therapists willing to share their patients with us. So we've got Brianne Savage, who, like Brianne was just telling us, she's in the process. She's just made a move. She had established this wonderful facility. And I mean, they were going to town. They had the therapy room. I mean, we had watched all your progress, Brianne, on Facebook, and we were so excited for you. But another opportunity arose and they took it, and they are now in Georgia with, as we're seeing, a computer, a printer, and a bed on the floor, and they're waiting for the rest of their things. But we're so appreciative, Brianne, that you are here and are willing to share. We've got Michelle Winer, who's also got a patient and or patients to share. And then also, Jodi, where did you go now? Jodi Haugen is also going to be sharing patients. So the topic that we had discussed, that I think Brianne actually was the one who kind of initiated this, was our more complex patients. We've kind of gone just, diagnosis by diagnosis, but we don't talk a lot about these larger kids, these more involved kids, and, who do we take and who, do we say, well, we'll work with, but perhaps not with using equine movement. And so, for some of us, it may just be that we need to become educated as to options. So before we start, I wanted to take a minute. I developed a really quick PowerPoint, and I just wanted to kind of go over a few things, and then we'll decide, Brianne, we should go with you first. But let me go ahead and see if I can share my screen real quick, just to... And I apologize, I have it up. Of course, it's not in slideshow mode, so I apologize. Let me get out and try that again. Slideshow. All right. So let me figure out what I'm doing wrong here.
Hello.
Hi.
Hi. Plug in my phone here for a moment. There we go. Yeah.
All right. Can you all see my screen?
Yes.
Yes, and I can see the full thing now.
Yeah.
Okay. All right. Yeah, I'm just going to do it this way because it's just a few slides, and I realize you can see the slides on the left. I don't have this in presenter mode, but I just wanted to kind of remind everybody about a few things here from the AHA perspective before we move on. Because of the sensitive nature of what we're going to be talking about. And I do expect, and actually I hope that we have disagreements or different thoughts with regards to, the patients. But what we want to make sure of is that, we are safety first. Also, the idea that we are encouraging evidence-based practice. And just a reminder of what evidence-based practice is that obviously we're looking at the research, not only the research that that we find through AHA or HEDI, but evidence in general related to our patient population. But it's also our clinical expertise. And one of the things that I do tend to find, especially with therapists first starting out, is that oftentimes they're working with their patients in a hippotherapy setting, and that patient population is different than what they've traditionally worked with in a clinical setting. And we really want to encourage that each therapist have a ability to work with that patient off the horse before they add, especially when we're talking about the complexity of some of these patients that we're going to be talking about here in a minute. You know, that you have the comfort and the ability to effectively treat these patients without the use of the movement of the horse before you add this additional layer. And then obviously it's the patient values and preferences, and it's going to be because the patients and or the families are interested in the use of this tool. And yet sometimes we have to realize that even though that's their preference, this may not be the appropriate tool. So, you know, but we are taking all of these into consideration. When we are considering inclusion of hippotherapy, we have to remind ourselves that we're the responsible party. We're the ones making sure that our treatment is safe and effective. And so each of us has to perform a risk-benefit analysis with regards to the inclusion of hippotherapy. We need to make sure that the entire team is in agreement that this is an appropriate patient that you're going to be working with, and that you want to have reviewed the current list of precautions and contraindications. So what are precautions? When we're considering this, it just means we need to get more information and we need to move cautiously. We're going to determine if we have the appropriate horse, if we have the appropriate team, whether we're going to be able to safely transition a patient on and off the horse. We're going to determine if we have the ability to assist the patient if an emergency dismount is required. So sometimes we can get these patients on and off, you know, from the mounting ramp or from the use of an overhead lift. But if we were to have to take them off and they ended up on the ground in the middle of the arena, are we then going to be able to assist them appropriately? And are we going to be able to monitor them throughout the treatment session? So then, of course, there's the contraindications, and we all have to be aware of the contraindications, because these are the ones that it doesn't matter, you know, what we think. These are the ones that we are gonna have to say no to. That AHA does provide the list. We look to PATH also for guidance with regards to this, and we realize that this is a changing list. It is subject to periodic review, and I will say that there are a lot fewer contraindications than there used to be. We want to make sure that we're continually reevaluating our patients too, because sometimes they may be contraindicated initially and then they're not down the road, or vice versa. So we need to maintain our up-to-date information regarding their health and functional status. And we know that contraindications are raising safety, liability, and credibility issues. So our absolute contraindications, I'm just going to run through these really quickly because I just want to make sure that we're all on the same page. So active mental health disorders that are basically going to create safety challenges, an acute herniated disc, Chiari-2 malformation with neurological symptoms, atlantoaxial instability with a displacement that's greater than 4 millimeters in a child, whether they have neurological signs or not, or if it's less than that with neurological signs. as assessed by a qualified physician. And of course, we realize that Down syndrome and JRA are two primary populations, but this can be seen in a variety of other diagnoses as well. The coxarthrosis, which is basically a flattening of the femoral head, which makes the hip function as a hip joint, so there's no abduction or circumduction. Grand mal seizures that are uncontrolled, hemophilia with a recent history of bleeding episodes, medical conditions during acute exacerbations, such as with multiple sclerosis, rheumatoid arthritis, diabetes, an indwelling urethral catheter, open wounds over a weight-bearing surface, pathological fractures without successful treatment of the underlying pathology. So our patients with severe osteoporosis, and again, keep in mind, a lot of our very complex, non-mobile patients can fall into this category. Osteogenesis imperfecta, bone tumor, those are other categories. Tethered cord with symptoms, and unstable spine or joints, including unstable internal hardware. And then what I wanted to just remind you all is that PATH provides for us a whole list of precautions and contraindications based on diagnosis. So they are the resource for obtaining these precautions and contraindications. I have taken them and moved them into a Word document. So if anybody, which is going from PDF to Word isn't super clean, but I do have that list. And so if anybody is like in desperate need of getting it, just email me or message me and I can get you that list. But since atlantoaxial instability tends to be a topic that we discuss, I had just, pulled a variety of neurological signs for atlantoaxial instability that I got off of the PATH standards. And then that continues the signs and then the absolute contraindications. So just kind of showing you the example of what you can obtain through the PATH standards. So I am going to stop sharing, and I am actually going to pass the baton to Brianne. We did not practice any screen sharing today. But the screen sharing should be.
You want me to try it?
Sorry, I just want to make sure that it says that it can be shared with all participants who can start sharing when someone else is sharing. I'm just going to say all participants. All right. Okay, and I just need to respond to this one person who did not. Is she on here? So Brianne, I know you've turned your microphone off. Are you, and it doesn't seem like we've gotten to the point where you're screen sharing yet.
Oh, I'm sorry. I thought you were still working on sorry.
Oh, no, I was sending it to you so I could deal with the other.
All right. Can you see it now?
Yes.
And you might see, this is just what I have for our center. So you might see some random photos. So you can see some of our pictures we had done when we first opened. So first off, that's my son in the middle there. This is taken 2 years ago. So I have personal experience with hippotherapy. This is actually what got me started, is he started as a young, I think he was 3 when he started. So let me scroll down, sorry. All of our progress on the farm, you can see in like 2 seconds here. And I tried finding videos and pictures, and I do have pictures, but unfortunately, I don't have a lot of videos, and I don't have tons of pictures because mainly I was a sidewalker, hands-on, so I didn't get a lot of pictures. We didn't have tons of volunteers and helpers. We're a very, very small clinic. So, so the first little girl that we can talk about is Ani. I can make it work. Come on, there we go. So I don't have a slideshow or anything, but this is Ani. I don't, and I apologize too, because since we've moved, I don't even have any of their evaluations or anything in front of me. That's all in our stuff that's supposed to be delivered this week. So this is Ani. She is only 4 years old, but she's very, very tall for her age, which is part of the reason why I was wanting to bring up this discussion. So she has cerebral palsy and has fairly decent neck control, but it's on and off. It's not a constant full neck control. She is good with using a helmet. And this is her on our smallest pony, Tucker, who is a very tall 12.2 hands or little pony. And he was one of our favorites. He is an amazing boy. So this is just her first sitting on him. We were just looking to see size-wise how she fit on him, how she sat on him, how she felt about sitting on him, that type of thing. So this was actually part of the evaluation. So you can kind of see the size of our little Tucker here. Okay. So this is her mother and her in her wheelchair. So how we had the setup is they would actually back into our arena right here. And so she could have her wheelchair and stuff right here on the concrete. And this was one of our therapy horses, Ivy, who is no longer with us, unfortunately. I don't have a lot of pictures. It's my son and his riding. So this picture in particular, come on. So I went to that Part 2 course down in North Carolina, and Miranda has this wonderful little thing called the Hippo Helper, which is right here. And so we have just a little bit of a towel over it because there's Velcro right here where you can add additional like foam blocks for a higher height for an older child, a bigger child. And this works really well. So we have her gait belt right here. And then we put this over and around her. She has her helmet on. So there's always 2 volunteers, one on each side. So you can kind of see the hip spread as well for her. She has a little bit more mobility than the next child we'll talk about. And she did really well with this horse. This horse is a quarter horse. She is 15 hands, I do believe she was. And this was a great horse for her temperament wise and movement wise. The reason I questioned some and wanted to have this discussion was, as you can see, since she's about a 15-hand horse, she's taller. And you can see my volunteer here, who is, I do believe, maybe 5'3". She's not super tall. So that's my question is, she does need trunk support. Doesn't really need a lot of neck support, this one does. But, we need a lot of work on keeping her hands flat and down on the Hippo Helper. She has some tone issues there. So, as she's only 4 here. This is her first summer here, and she's very tall for her age. So what we're planning on doing once we get restarted down here in Georgia is trying to find another smaller pony, another 12-hand pony-ish, because that reaching up and trying to stabilize has been difficult. And also relying on volunteers to help with the sidewalking. You know, I'm very hands-on with these children because I have a lot of anxiety. I want to feel what they're doing. I want to feel their movement. So I want to make sure I have sidewalkers that are really well trained with this. And this isn't really super easy for even the trained, skilled sidewalkers that I have. And we just don't have a lot because we're pretty small. So that was one of the questions I'd love to get feedback on.
Okay,
So-
well, why don't we stop it on that child right there? And
go back
get
to that
some more
picture?
information and then just let people, in fact, if everybody has seen her, why don't we go ahead and stop sharing for a moment so that we can see everybody's faces and everybody can have an opportunity to either ask you questions or provide you with ideas. So I certainly have questions and ideas, but I would love for others to step up first. If anybody else has questions for Brianne to get more information, or looks like Sherry does.
Yeah, so my question is cognitively, where is she at with her communication and receptive and expressive? Because when I work with some cerebral palsy children that I've had even at a very young age, if I work with them prior to getting on the horse and work with them on actually it's sort of a letting go and softening of their muscles during relaxation and that type of thing. Then we go back when we move them onto the horse. I talk about them going to that point of softening because we want their backs to be unlocked. We want their shoulders to be soft. And actually, I've had very young cerebral palsy children that actually can get that. So just, you know, that might be something, even if they're not totally verbal, sometimes their receptive language, they can understand that, especially if you work with them in the clinic on the mat or other things prior to. So you can, I'll wait and you can share.
Yeah, so both of the kids I'm sharing today are nonverbal. Both of them, what I do the same with as I do with my son, is we don't have 100% true understanding of what they know or don't know. So I always assume competence. And so I ask for things. And I would say she's, you know, she does more than 50-50. She's, I feel like her cognition is it's not normal, but I think it's somewhat functional that I can do some basic directions like head up and, you know, that type of thing. Some very simple one-step directions she can follow. Obviously, I won't be seeing her down here in Georgia, but when I encounter children like this, again, I want to make sure that we are troubleshooting that. So we also do some like stretching and some general range of motion usually before we get on the horse, so I can kind of see what their hips look like before we're thinking of getting on there.
So some of our kids will do some myofascial work, and not everybody's trained in that, but you can do courses on that. I'm very blessed to have a therapist that is a trained trainer, but I've also done some work as well. And sometimes that low back is so tight in these kiddos and their shoulders and all that. So doing some of the myofascial, even with facilitation while you're walking and touching that low back and saying soften, soften. You get to move with the horse. Even at that young age, sometimes they understand that. Yeah, I like that helper thing to push up.
Yeah. So wave down through her arms. So I was kind of cue her to kind of push up through her arms and head up, and she can get that. Now this picture that I shared earlier, that's actually a good picture of her working on sitting up. She doesn't always maintain that posture. Sometimes she is kind of very flexed. So that is her responding.
Yeah, depending upon the barometric pressure, the weather, what they've been through. There's so many factors, even with barometric pressure on these kids that have that low tone, but looks like spastic tone, can be very exhausting. So yeah, I'll let anybody else share if I'll turn mine to mute.
So Brianne, I do have a question about her tone. She doesn't look like she has a lot of hypertonicity, at least in the picture that you showed. She almost looked like she had hypotonicity, at least in her trunk. Can you tell us a little bit more about
Well, she
about her
definitely
toes?
has central hypotonicity,
Mhm.
but it's more limb.
Yes,
No, she's not severe. She's not too bad, but she
right.
definitely has some tightness in her hips, particularly. Most of
Mhm.
these kids do. And the hands that you see, how they're kind of flat like that, we were working on stretching, and
Mhm.
she's actually shown a really positive response with the movement, because as she's working on pushing up, she's kind of pushing with those hands down, and we're cueing her quite a bit. Because where we have our hands is we have one hand usually on her forearm to kind of help with that facilitation, to kind of weight bear through her forearm. And then one is usually behind her to either support her trunk as needed, or just be there in case of you know, a lean, or, you know, that type of thing. So, or possibly the upper thigh. So it just depends on the child and their need. But for her particularly, I know we put one hand on her kind of forearm area to kind of help work on flattening out that hand, weight bearing through the forearms.
And then my other question to you is, do you use bareback pads on the horses?
Yep. Mm-hmm.
Okay, because I know
So
you didn't use it for the trial, but I didn't see it in the other picture either. So
yeah,
that's
you know what, you can't, I'm kind of surprised. You can see, when you see the picture again, you'll see the strap that goes underneath the horse, the girth. It's actually one of Miranda's too, one of those, it's the small brown pads that she has. So it's there's no actual padding to it. It's just a pad.
Yes, I was
But that
ready
makes
to say that I liked so much that you had no pads for a moment, because I try with my children to have no pad straight to the back of the horse, but not
Yeah.
always. But I try
So-
also.
So this one,
Mm.
it's very thin. I mean, it's not a, I know a lot of people will use the fleece, but it's a really thin, I don't know that I have a picture of it, but again, it's one that I ordered through Shining Hope Farms. So she has a couple different sizes. So we got, I think, the small and the medium. So this might be the small. She might have needed to go up to a medium.
okay.
Just a little comment about that as well. When a child is sitting with rounded back, that tailbone, a bigger child, obviously a little child isn't going to be a problem, but when they're rounded like that, then that tailbone is going to hit into the spine, because when you're sitting up, then you're on your two seat bones, but when you're rounded like that, so we kind of tell the kids at our center, we just kind of always believe that they understand, you know what I mean, from the get-go, and we do some evaluations, but you know, we kind of actually share, even with the nonverbals, we need to stretch up, not this one because, but when we do camps as well, we work on that, you know, like, because if they are no pads at all and they're bigger and hit that spine, horses can shoot forward or do other things like that. So she's little, but you know, that's just something to be considered without a pad.
Yeah, I also wanted to, I don't have one at the clinic, but this is one of my wish list items, is I want to get like a small, like, foam wedge to kind of help with that rounded back sacral sitting, to kind of help them give a little more upright posture, and also to help pad the horse exactly. But yeah, that was one of my wish list items I'm still working on. We're self-funded right now, so.
Absolutely.
Sometimes you can use, like, I've used Beanie Babies, and I've used rolled up towels and that kind of stuff to help with the
Yeah.
sacral sitting if you just want to lift the butt, and that's pretty cheap. I mean, obviously make sure it's a flat Beanie Baby, but some of the cats are pretty flat, and the dogs, and the kids think it's hysterical that then they're sitting on a stuffed animal. But it just gives you like a 1/2 inch to 1 inch under their butt. I wouldn't use that as a pad, just more if you're looking at the hip correction. And a folded towel. You can use a wedge too, but sometimes that's too much for me. And I'm like, I just want that 1/2 inch of a folded hand towel underneath their butt or something like that.
So Brianne, I have a couple of things that I've tried in the past, and one of them is, you know, we want to get a little bit more upright sitting. And I can't tell, but I'm concerned that her leaning forward is kind of a residual of STNR. So if she's leaning forward, she's going to have that natural flexion in her arms and going to have a great deal of difficulty extending. So what I tend to do, especially for someone with that short of a trunk, is not use a gait belt, but use something like an abdominal binder or even a life jacket. And I would hold her more under her armpits where I'd have more of a control of her trunk and try to get that lower back active and get her out of that possibly reflex encouraging position, because you're never, if that is what's happening, if it's only partially there, then you're going to continue to get that flexion.
Didn't see it as a reflex, but it could be. She also, that horse is 15 hands. That's the hard part about getting up there.
Well, you'd be under her armpit, which with her short trunk, you're not much higher than where she would be on the gait belt. Plus, you'd be giving some compression to her thoracic cavity.
Yeah, that's true.
Which may give her something to stabilize off of rather than propping on her arms.
Okay.
And then just kind of thinking about if you want to get some hand flattening, I find, and I thought the Beanie Baby idea was cute to sit on, but you can also, if you give them something to hold down, like hold the kitty until we get to the green barrel, then their hands become more active rather than keep your hands down and her arms constantly want to flex. If we give her, hey, hold that cat down until we get there, hold it, hold it, hold it. I mean, I don't know. It just makes it more of a game and less of an exercise.
Well, and that's where I really liked your guys' help, because my background is I did mostly geriatric, home health, hospital, acute care. I did outpatient for a long time too, but most of my pediatric experience is because I have a 9-year-old with CP.
Well,
So my
resume.
pediatric hat, as far as like treatment, I'm okay. It's more the think outside the box games, that type of thing that I am not experienced in yet. So
the other thing is that we really want to get away from that forward head, which she's in that way, the way she's sitting in her stroller. It's because of the tilt. It gives her that her head and her shoulders are stuck. I mean, so anything we can get on that horse to get her a little more upright, give her some support in that thoracic cavity, make that lower back a little bit more active. We can work towards better posture. And I don't know about the STNR. I'm just kind of guessing.
Yeah, no, I appreciate that.
Okay.
And I think somebody's in the chat is talking about increased lumbar extension. In a prone. Yeah. Actually, my son had that done and he did great with that, because he's also very rounded shoulders, kind of forward flexed. So when he was younger, we put him over the horse. I don't know how to describe it, but right over the barrel of the horse. So one volunteer was on one side, one volunteer was on the other. And yeah, he had to actually use the horse to kind of work on that really great extension in his lumbar. And it was great, or thoracic actually more. But yeah, he really improved and he really liked it actually. So yeah, that's definitely an option too, I would think. If anybody else has any ideas about prone work on the horse, that would be great.
What I tried for this upright position was to put a very soft ball, small soft ball, straight down the spine of the child, in his buttocks, her buttocks. You understand me?
Yep.
Brianne, maybe I can send you photos or videos how you use
No,
this ball.
his PT has actually done that with my son. They put the ball down there and they really kind of roll.
I put the ball under her buttocks.
Oh, a small little one. Okay.
Small one. It like as we have in physiotherapy room. I don't know the word. Anyway, I can send you some photos or videos to see how I do it, and it works.
Wow.
Or maybe more backwards to move her. But have you any good conversation? No, or how does she understand you? She's what is mentally retarded? How is?
Yeah, developmentally disabled. Yep.
is severely mentally retarded, or she understands?
Moderate. I don't have a full
Moderate.
picture. Yeah, mild to moderate. I mean, we don't 100% know she's nonverbal, but she does follow some basic instructions.
I'm going to wait to see if anybody else
Carol,
has
if
any.
I,
Well, you know,
this is,
you could test her reflexes as well, and then just recognize that what you would do in the clinic to inhibit the reflexes, you can actually think about how you can do it on the horse as well. And we have the advantage that we are moving through space that whole time, and our brains are all lit up. And if we do hand over hand, then we can build new motor pathways. So when we're putting them in positions opposite of the reflex, then we are actually going to help that get integrated. It's so cool when it happens. So you can kind of be thinking about that as you work with her.
Thank you. I really appreciate that. I will pay a little closer attention to that too, because I'm a PTA. So my PT does the evaluations. So no, that's okay. No, when I read the evaluations, those are things I need to maybe cue in on more. Is okay, let's think about this. Yeah, no, perfect. Thank you.
Well, I'm not a PT, and gait things are not my things. So
All right. Well, Joanne is a PT, so she's gonna.
yeah, let me throw out, and Karen, your ideas are awesome. And just to add to that, remember that even with PATH, you do have options for alternative lightweight helmets. And although she does seem to be able to hold her head up in a static position, that forward head and that difficulty in maintaining that neck control, especially if her trunk is hypotonic, think about some of those ultra lightweight, like the thud guards or the bumper bonnets or those kinds of things as an alternative, I think might be helpful. Along with that, Karen had mentioned like an abdominal binder, but the other thing that she may even already have would be something like a Theratogs or a Spio or something under her clothes. And then that gives you a little bit of help. So you're not working so hard on trying to get all those body parts, but if she's a little low tone, that just bumps it up without creating or without doing it for her, but just giving her that input to activate her trunk a little bit. And then you can concentrate a little bit elsewhere, because those are the kids that are always just tough to manage. And especially if they're on a 15-hand horse, because I'm only 5'1½", so I can relate.
Yeah, and that's actually one we had our the little horse that I showed you earlier. He actually just passed away 2 weeks ago. He was in his 30s. So we are looking at, once we get settled and we have things a little better here, we are actively looking for another 12, maybe 13-hand horse for some of these kiddos, maybe a little stouter. So maybe another halflinger or the like, that can help us with that. Also, the great thing about Tucker though, was he was a Hackney pony. So he actually was fairly narrow at the withers, which was great for our kiddos that did not have great abduction in their hips, which is our next kiddo that I was going to show you. So yeah, I guess that would be the next thing, is horse selection is really important with these kiddos. We are down to 2 right now. So we will actively be looking for 2 more horses to help round that out. So one's 13 hands, but she's gaited and she's a little more forward. So she's not going to be great for some of our kiddos that are not as strong. And we also have another 15-hand Paint, who is an absolute doll, and he's very gentle, very slow, very calm. But again, he's a pretty tall guy. So I guess maybe that would be my next question, is what kind of horses do you guys work with for these kiddos? That I don't know if you found one that works great for them, if it's just, luck of the draw of what you got. Obviously we can't have all the horses we want, but I'd love a discussion on choosing the horses for these kiddos.
If I can sort of address that, but also in a way of talking about some of the positioning, the discussion about how rounded she was and increasing that extension, and this would go to whether or not you have a horse that is appropriate size, is getting your patient into a supine position. It also kind of dovetails on what Joanne was talking about. You really need to have a soft helmet versus a hard helmet to be able to use some of these alternative positions like supine, and you need to have appropriate padding for their head and neck area. But it's a really great way to open up that anterior chest wall, get some nice lumbar extension, get some relaxation of that spine right along the horse's spine. But you do need to have, you know, the patient can't be so long that you're you know, going over the croup of the horse. And the horse has to be really tolerant and be able to have that nice little tiptoe gait. This isn't a position that you can have a real forward horse in. You know, it has to have that really low, as Karen loves to say, and I quote her all the time, 100 speeds of walk. You need that little tiny walk to be able to not give too much input. You know, you have to be very careful of their neck, have to have a lot of protection there. But those kiddos who are really kyphotic and they're really collapsed and they've got that forward head, you can really get a nice chin tuck, an elongation of their spine, and also a nice stretch to their abdominals. I find a lot of those kiddos are actually really, really tight in their abdominals and their psoas, and they're losing that lumbar extension because they spend so much of their day in a sitting flexed position. So I don't let legs kind of hang over. I always have like a boppy kind of over the horse where I can put their have it under their knees to sort of give some relief to their lumbar spine, because a lot of them are so tight, their hip flexors are so tight that they just arch right up. And you want to be able to make sure you can get that spine in contact. So, you know, a horse that's broad enough to and able to be graded down enough to do that. And it's also a position that I don't stay in for a really long time. You know, sometimes you could feel the difference in the patient within like one time or maybe two times around the arena, one in one direction and one in the other. And you can literally feel that patient just almost like melt into the horse. And now you've seen that you've made a change. And then I would take that boppy that I had, their legs over, and I might sit them up and put it around them to give them some support. And I really love what Joanne said about using like Theratogs or like a Spio vest if they had it. I used to have, when kids outgrew them, the parents would often donate them. So I had them and I'd put them on over the kids' clothes. So I have different sizes. But that can also kind of help give them some input and give you a little bit of support.
Awesome. Yeah.
But
No,
you
my
do,
friend used Theratogs, and he did the same thing. Actually, he did a lot of supine beforehand. Now they only did it more of a stretch versus active movement. But I actually really like that. That's an awesome idea.
I would sometimes get them to actively stretch their pecs with their arms out. And it's sometimes a position that we moved in and out of. We went into sitting, we worked on that upright posture and sitting after we got some relaxation. And then as they fatigued, we would lay back down and we could work in and out of those positions.
Thank you. That was awesome. That's great.
Just another thought. We do a fair bit of prone laying sideways over the horse as well. And when I was first taught that, I was taught to always stand between the child's legs, so you're facing forward, and to flex one. Have other people done that? Someone told me it was to break the reflex pattern, but I don't know. So I just thought I'd ask if other people do that, if you've had any experience with that, if it's necessary or not. It certainly helps to break a lot of that extension pattern.
If they have a lot of extension tone, I would say, yeah, my 9-year-old, when he chooses to, if he gets upset or really emotional, he will definitely plank into a hard extension, and definitely flexing at any point helps him break that up. And if it's a large enough horse, he should get enough hip flexion in there too to help break that up. But I just have to be careful with the horse that they're not kneeing the horse or anything either. But yeah, yeah, kind of breaking that up. Even just, it doesn't have to be, a 90-degree bend in the knee, but just enough to kind of break that up a little bit, really prevent him from locking those knees out.
Yeah.
And if I can just add one more thing, because it made me, you made me think of it. With those types of alternative positions, I think you need a lot more padding on your horse than a small bareback pad. You really need to have, the patient should have a pad under all parts of the horse that they're in contact with, because it just protects the horse. And it gives some protection to the patient as well, but you need to think about what you're using for tack for your horse, to make sure you have like a nice big Western pad maybe, or a big thick fleece pad. It just if you're going to be adding, doing different positions like that, you wouldn't want to have your patient knee touching that horse on near his flank or anything like that.
Yeah.
So,
and another big benefit of those positions is the warmth, obviously, that we're getting coming up from the horse, and there's more of their body is receptive to that. And so then that is also, we find it helps reduce tone significantly as well from that.
And Brianne, I love all these ideas, and I do agree with Mary Helene as far as patting the horse, but I also do realize, that with some of your kiddos, like the one you're going to show us next, that, if you put on a nice big thick Western pad, you may create too much width. And then especially for our kiddos who've got the tone in their adductors, that may be too much. So there are ways to pad the horse. I know that I've had the, gosh, now I'm going to blank on it, the thin line pads are literally very, very thin. And then just a nice waffle weave dressage pad. So a waffle weave dressage and a thin line, and then something over that. It's not as thick as the Western pads, but it's still a lot of protection for the horse and for the patient. Because too, especially if you are getting them into supine, which is a great, option that Mary Helene presented, that's going to be spine over spine. And it's wonderful, that spine of the horse is translating to the spine of our patient, but we don't necessarily need to have spinous process to spinous process. So, we do want to have them padded. And also too, with what Joanne had said about the SPIO and the Benix or the other types of vests. Now that you've moved to Georgia, the downside is that you're in a much warmer climate, and you have to be careful about that. And so the other suggestion Joanne had made was the abdominal binder, and that's going to be more heat tolerant and still give you some good intra-abdominal support.
I just wanted to add before we moved on that I have several kids like this, only they're bigger now because I've had them for a few years, and that they come in their wheelchairs, and I always start them in the room, and I do supine over the ball and use the myofascial techniques to lengthen those abdominals and those shoulders and that chest, and just get some relaxation, on the ball to prep them to be up on the horse. And that really has, proven to be really beneficial. And if they're shorter on one side, I'll also put them in sideline to lengthen that shorter side on the ball before getting them on the horse. And I've seen phenomenal changes in posture being much straighter, scoliosis being decreased, much more upper trunk extension. So it's been very successful using that as preliminarily, because those bigger kids, I really can't do supine on the horse. I mean, the one boy I have now is 18, but I've had him for 7 years. And the other ones are like going into 7th grade now. So, you know, they're a little bit bigger, they're a little harder to handle up on the horse, but their control and their symmetry has improved so much. I don't have to provide a lot of control anymore. Where we started with the hippo helpers and we started with all kinds of other devices, and now I don't have to use those with those kids because they've gained so much more stability in their own trunk control just through utilizing the movement.
How much time on the ball before going on the horse? 10 minutes, 5 minutes?
Well, I start the kids in the room and I see them in the room for a good 25 minutes. And then they go on the horse for 20 minutes at the end. So I do a lot of stretching and a lot of preparatory things, you know, with those more severe kids before I get them, you know, on the horse, just because it makes it easier, especially if they've got adductor tightness, you know, work on that a little bit so that, you know, we can actually get the legs apart on the horse. But then the horse just eventually, I mean, I see total relaxation after they're on the horse then. So that, you know, and some of them I don't have any difficulty getting on, and real successful. One girl's had releases 5 years ago in the adductors, and she's just saw her surgeon and he said, I am just so amazed. He goes, I expected her to come back and need more surgery. She's totally maintained everything, all the lengthenings that they did just through using the hippotherapy or the riding on the horse.
There are a number, oh, sorry, there is a number of very nice comments, you know, so you'll want to read those. There's some new different ideas too on helmets, and some that I'm not familiar with. I've never heard of a HUIFEN, which is Velcro adjustable. Michelle, that was yours. Or I guess Joanne, you also were mentioning that.
Yeah, there's several brands out there, and I've kind of experimented a little bit. It's, you know, that old Amazon thing where there's like 18 different brands of the exact same thing. So I did a quick search and that's what I came up with immediately, but you can go on there and you can find some, but some of them Velcro in the front and the back and over the top. So you can do a lot of adjustments and a lot of sizing for the kids, and they're basically all foam. They're not going to provide a lot of safety, but they are within the realm of the PATH standards for alternative helmets. So
that's kind of a perfect segue into my next kiddo.
Okay.
Okay. So you guys are going to do a nice little gasp here because we are not following. Just wanted a disclaimer. This is not approved. So this little guy here. Oh, I need to share, don't I? Hold on. Sorry. I'm like computer illiterate here. There we go. Are we seeing it now?
Yes.
Okay. So this little boy is Waylon. He just turned 3, but when he started, he was 2.5. So you can see he is not wearing a helmet. We were in the process. So he started his evaluation was in July, but he didn't start mounting activities until August, September. And this was taken in December. So we were working on finding an alternative for him because he has pretty severe microcephaly. I'm not even sure that it shows up that well in this picture because he's wearing that cute little hat, but his head was incredibly small. We tried a couple alternatives that it still was they were too big for him. And also the big concern at that point for him is he has very poor head control. So it looks nice here or okay here, but you can see in some of the photos here, he has what he will do is he'll kind of throw his head back when he laughs or when he moves. So he also has a vision disorder called CVI. So a lot of his behavior will be doing this to kind of look this way because he's often like this. So he'll kind of use that cervical extension for vision. It's not all just a floppy head. He's not flopping around there. So this little boy has severe HIE. And really his goal was to work on a neutral cervical spine for, I think it was 30 seconds. And he did like a couple minutes in this session right here. We did very little active motion. It was very short, very slow when we did it. And then we would stop and work with him on kind of tucking the chin in and working on that upright posture. What you probably don't see, well, you might see a little bit here. If you look at this photo where his hip is versus some of the photos here, you can kind of see it's much more forward. When he starts out, we do stretching in the clinic first to check his range of motion, his tone. He has very high tone in his joints. He already at 2.5 already underwent double hip surgery because of hip dysplasia. So he already underwent that, and he was actually in recovery from that. He did get signed off by his orthopedic, but that's part of why he was so tight. So when we first started with this little boy, he could not sit on this little guy. And I don't know if you can appreciate how small this horse is, but he is a very little guy. And he could not sit in this normal position. He had to sit side saddle. And we didn't, again, do a lot of movement with him to start with. We also did a couple, like I said, these are not organized, I apologize. We did a couple sessions. He has a Hansinger collar. If you guys are familiar with that, we've used that intermittently. But one problem with that collar is he then relies on it. He doesn't do as much active work with his body. And he just kind of is more of he just kind of sits there. So, and if you see his face right here, I mean, this little boy, I can't even tell you the difference in him versus his clinic evaluation. We were very concerned that he wouldn't even be a great candidate because I'm trying to find the picture of him when he first started. Of course, I'm not going to be able to find it. Oh, there's some. So this is just his evaluation. We actually didn't end up putting him on the horse. And that was mainly because he's very irritable in general. He cries in the car and he had a 45-minute drive. He is a kiddo that is very, I don't know what the word would be. If you guys can maybe help me describe it, but just a lot of sensory input. He just is very irritable, cries a lot, tones a lot when he's upset. So when he came to the clinic we did a very minimal evaluation. He just didn't tolerate a lot of handling. So we were very worried and concerned about how he would tolerate this. But when he started working with the horses, that's the response we got from him. I mean, this kid was full on giggling and laughing. And, when he came in for sessions, he was not upset. We could do some mat work and he was fine with that. So the farm environment, the horse, I'm not quite sure, it's kind of inexplainable 100%, but he has really come along, and you can really see, him opening up in those hips and really being able to, by the end of the session, we're able to pull that knee down and really kind of extend those legs down and get a good stretch with him. Right here, he was actually probably a little tonal there. But he also has little mittens on because this is December in Ohio. And actually think he did pretty good for the cold. So again, we're still using the hippo helper. And we were in the process. I know his mom is still trying some other facilities. Well, they will be trying to find a helmet for him. So that is in the works for him. And there's the size of the pony. So that will help you kind of understand how little this guy is. Trying to think of anything else. Any other questions? I mean,
why don't we do the same thing we did before and go ahead and just stop sharing, Brianne, now that people have seen him, and see what questions or comments people have for him.
I work out of an RDA centre and we have a helmet exemption form which the doctors can fill out, which we are allowed to use then. We obviously always try and use a helmet if we can, but we actually are allowed to not use a helmet with some of our little ones where it's not the best idea. So I don't know if other people are allowed to do that or that's just us here in Australia.
And say that the high fun, what the one on Amazon that we posted, that one goes quite tiny because I just evaled a kid this week and I took an ovation extra small, and I think I could fit at least a full finger to 2 fingers on each side around his head inside the helmet. I was like, this could work. So I quickly grabbed, sent a volunteer to go find that one. And because it is Velcro adjustable, I was able to make it so it fit his head circumference, better.
And I will also say I'm a little more comfortable with him not having a helmet because of the size of the horse, because of the size of the patient. There was a lot of factors that kind of went into it. But that was kind of my main thing, is I felt comfortable that I could kind of do a cradle and pull him right off of little Tucker there. If that horse had been a 15-hand horse, a lot of other factors would have gone into it, but for this particular patient, we allowed it. But we were actively looking for alternatives. And in the United States, helmets are not required. It's not a legal requirement. However,
no, I think that depends on where you are, Brianne. It is
okay.
absolutely mandatory.
Right.
In Florida, where I have been, Gainesville, absolutely. If you were under 18, you must wear a helmet if you were on a horse. So it does depend on your locale.
Okay, I'm sorry, I apologize. Depending on the state, yes.
Okay, does anybody have any specifics? I mean, Mary Helene just got off. I think for him, the supine positioning that Mary Helene had described for that other child, I think could be really beneficial for this child. And then working, prone, either prone over the barrel of the horse or in a modified prone, again, spine along the spine of the horse. Could be wonderful for starting him to really develop that head control, depending upon how much support you are giving him. That is those types of positions, though, are going to take really controlled, graded movement of the horse, because you're not going to be able to have a really any kind of rapid cadence, for sure.
Yeah, this little guy, I mean, he was, I miss him so much. He was the perfect horse. He literally had a puppy temperament and a been there, done that Amish retired horse. So nothing, I think I saw, actually I've never seen him spook. He's tripped once, where we had to kind of grab a kid off just to make sure everybody was okay. But he was a rock star. And his graded movements are amazing. You could slow him down to almost nothing, and then he could be a very active walk. And it's going to be hard trying to find a new guy to replace him. So wish us luck, because he was one of a kind. But yeah, exactly. For these more complex kiddos, definitely a horse that can move to a crawl and will tolerate that, because I found one of my horses can do it. She doesn't like to do it, and it's taking her a little bit more work and training to get her tolerance level up for that kind of thing. So she's not there yet. But yeah, I mean, you just got to remember the horses have to enjoy this type of work, or at least tolerate it. Where we were in an indoor arena, and some horses hate the arena, and it was a smaller arena too. So it wasn't like you had a long wall. It was only 50 by 81. So the repetitiveness, the boring, the standing around, you definitely need a patient horse for kiddos like this.
So speaking of not having a long sides, is that going to be different where you are now in Georgia?
Yeah, so we have a couple extra acres, and we are starting from scratch. So where we were in Ohio, this arena was already there. And here we have literally nothing. We just built the fence a couple weeks before we moved in. So we are getting quotes right now for the barn. They have a run out shelter, but they don't have a barn. So we are literally able to put everything together. It's just going to take a little more time because unfortunately here in Georgia, everything is very wooded here. So you have to do a lot of clearing of the land. So we're going to be doing that to make a bigger outdoor arena. And then eventually the goal is to have it an open air covered and make it at least like twice the length.
Yeah.
The width
Yeah,
was
'cause that-
okay, but the length was definitely an issue.
Yeah, especially with these kiddos who are so involved. I mean, sagittal plane control is what they need to work on. And, you know, you're going to get sagittal plane before you get frontal plane and then transverse plane. And so that idea of those long straight lines is without a lot of directional changes can be very, very helpful. And, you know, even if other than in your enclosed arena, if you have some kind of long drive or some, you know, area that you can work, that I was fortunate very early on in my career when I was incorporating horses to literally have this long avenue of tree lined, you know, tree shaded, just this long path that was absolutely fantastic for, you know, for working with the more involved kids. So definitely encourage those long straight lines. Anybody else have any words of encouragement or comments with regards to this little guy?
I was just thinking about horse selection, right, because you had mentioned it. I personally like warm bloods a lot. But most people are going to roll their eyes right now. But honestly, when it comes to movement, I feel like they are amazing because if they're well trained, you can grade them super nicely. And I feel like with the more involved patients, I have had the experience that slower input, you know, that can be so well graded can be really helpful in terms of establishing trunk control and head control and all that. So just a thought when it comes to horse selection. The other thing, or the other breed that I really personally like a lot is those German riding ponies or Welsh ponies that are a lot like the warm blood, just smaller, so that you could be more hands-on. But I do feel like that they have a nice, like just the way the shoulders set up, they often have a nice forward reach, and I feel like you can grade it to where you have that input not as quick, but in a, I want to say in a timed manner that allows the client or the patient to receive and to answer the input physiologically, if that makes sense.
Sorry.
Thanks, Esther. Yeah, we've got a lot of chatting going on too here. So we're looking at all of this. Any recommendations for the larger wedges? We don't have any yet at our facility, just boppies. And Megan recommended the breast friend pillow, which I know Linda Fries has used, or a standard, a standard move and sit cushion. Okay, so like the Dynadisc, is that what you're talking about? That would be interesting.
Sometimes maybe we use many things on the horse with the child, and we lose the pure movements of the horse. I think that sometimes it's better to try to hold the child under his arms, or maybe some tapping on the back of the child, and how to say, not so many pillows or so many things.
I think it, yeah,
child.
I do. I think it depends on what you're working on, Maria. And yeah,
Yes,
you know,
of course, but,
sometimes more of those is not necessarily better. I know that Mary Helene had found at what she called one of the big box stores, so I'm guessing Walmart or something like that, and she shows it in a video of supine positioning in our part 1. And I know my daughter had one similar to that for years that we had to buy just because she had asthma and she couldn't lie down to sleep. So we had one of those big wedges. But the one that Mary Helene found was pretty cool because it had a concave side and then a flat side. And so the concave side could either be placed on the horse to be more supported to the shape of the horse, or turn it around so that it more supported the patient. But I couldn't tell you what it's called. And she's
Yeah,
off.
no, that was something I had purchased, the one that's in the part 1, and
Okay.
it was from Bed Bath & Beyond. But sorry, you guys, that's not an option
Oh,
anymore.
yeah, not a
But
thing
there's,
anymore.
yeah, probably Walmart, Target, one of those kinds of places that makes, standard bed pillows. The other thing I had fun with, I've done several times, is go to upholstery shops.
Yes.
And they have remnant pieces of foam, and get out somebody with a bread knife, an electric bread knife. and
Electric
you
carving
can-
knife. Yeah.
Yeah, and you can
Okay.
just cut it to whatever shapes that you want and just cover it with a pillowcase, or if you have somebody that can sew.
I do exactly the same for, creating things. And then I also use spray adhesive. So if you need to shape something, like you talked about having a concave with either an upholstery shop, because they have a variety of densities. And so you can go in and, like she said, they'll have remnants in a corner and some spray adhesive and an electric carving knife, and you can make anything you want. And then I use pillowcases because then I change them out for each patient. And so they may not be pretty, but they can be very customizable and inexpensive.
Yeah, and another piece of equipment that nobody has mentioned so far that I absolutely love, but it does take the taller person, is a small physio roll or a peanut. And I like to use those behind the patient. They adapt very well to the contour of the horse and to the contour of the patient's spine. And so when they're behind the patient, to help facilitate that pelvic alignment that we were talking about, Brianne, earlier, especially for that little girl. And then what it offers you is a really nice support for your elbow. And then you can have your hand, like if you had, elbow of you and your sidewalker, and then your hands can be on the patient's shoulder, or you could have your hand, say, on anterior on the sternum and between the scapulas, as long as the sidewalker at least has their elbow stabilizing the physio roll on the other side. But I just have loved using that to help get the upright position of the pelvis and the lumbar spine.
Well, Carol, I think you're a bit taller than I am, because I tried that actually with the patient that I submitted the pictures and video of, and my sidewalker and we decided we were both just too short.
Oh, I'm sorry. Or your horse was too tall, or your patient was too tall.
And my horse is pretty short too, but not I had access to a shorter horse, but she was not appropriate for the patient. So, but yeah, I was like, oh, I could see how it would work.
Yeah.
It just, my arm ended up like this instead of here.
I'm sorry. Yeah. I mean, I know I'm taller than the average, and I have a long wingspan. So I have huge hands. So it's like all the advantages for being a therapist, but I know not everybody.
I'm curious then, how many horses do you guys have for selection? Like, we normally had 3 when I was in Ohio. Now we're down to 2. So obviously we're very limited right now. We're already planning on filling that gap, but how many, like, we own our horses, it's our own facility. So I'm curious to know kind of what you have at your availability.
I think where I am, I was looking at the list before, it looks like we have 9, but we're a big barn. Yeah, Brianne, I'm in Georgia also, so you are welcome to come visit me.
Yes, I will take you up on that. Don't think I won't.
Yeah, so come visit, you can see, but we're a pretty big facility. because we have a therapeutic / adaptive riding program, school program, as well as the therapy piece, a border barn. So we're big. We have a lot, I mean, there's a lot of horses on the property. So approved for therapy is 9 of the probably 15 to 20 that are used for therapeutic programming overall. So yeah, every now and then I'm like, I need that email of the horse list again. So I make so that I make sure I'm using everyone who is, whoever is available and is appropriate.
How many acres do you have, Brianne?
I have about 11.
Oh, okay. I only had 5 acres, but I had 5 horses. I maxed what I was allowed to have, 1 per acre. And 5 worked very nicely for me. And we ran only about 25 sessions per week. So that gave us the variety that we needed.
Yeah, I mean, I'm comfortable with maybe 4 is probably what I would go up to, just from what we can handle, and just because we have to take care of them all. We don't have volunteers here right now.
Yep.
We don't have staff. We don't have, it's not a boarding barn. It's just ours. So, I have kiddos. I have other things going on too. So 4 is what I'm comfortable with. But that's why I was just curious what other people had available.
Are you located near any kind of schools, colleges?
I have no idea. Well, I mean, we're near Atlanta. So, I mean, I'm sure there's plenty around. I just haven't had a chance to really explore yet.
Now that's where I got all my volunteers, was from the university and the community college. So between, if you're, I don't know where the vet school is in Georgia, but, I know there's only 1 vet school per state or whatever, but, you can get the horsey people that way, or a school that's offering any kind of equine studies. And then of course, all the different therapy, but, there's a lot of college students who had to leave their horses at home or had to sell their horses to go to college, who would give anything to just come spend time with your horses. And, I ended up with 40 plus volunteers in a given semester. So I ended up with more than I needed. So you can, I would definitely look for a community college or university, or find whoever's close to you. All right. Well, thank you, Brianne, for sharing all that. Hopefully we've given you some ideas, and everybody else some ideas. Let's go ahead and let me see who I have lost. Jodi? I'm not seeing Jodi. So Michelle, why don't you?
Let me share my screen.
Oh, okay. Jodi's waiting to come in. So we must have lost her. Okay.
Can you guys see my screen?
Yes.
Yep.
Is it big? Okay.
Yes.
So all these pictures with him on the mat are at his eval. I was checking, obviously, lower extremity range of motion. Checking where we were. Okay. This boy came in CP, GMFCS 5, also CVI, the cortical visual impairment. He was a preemie, spent some time in the NICU, has seizures, but they're medically controlled. He had hip surgery a year and a half maybe before I saw him, 2 years, something like that. His orthopedic surgeon actually at one point was on the board of the horse park. So he's well aware of what we do, and he's the one who wrote the referral to us. So sometimes this is a nice referral source for us. He's nonverbal. Had apparently been on a horse before in therapy sessions when he was very little. I didn't get great details on that. His aunt had actually taken at least the AHA level 1 to have more information about using horses in therapy, because she herself is a speech pathologist. And she came to maybe, I think she doesn't practice, and I think she came to like the second session and was very, very happy to see I did not have him on a horse, because she was really concerned because he does not have very good head control. You actually, one of the pictures, you can see it. In this one, you can sort of see we were just getting on and getting settled and organized in this picture. So you can see how
Michelle,
poor
that's
his,
very clever. So that looks like 2 boppies and a
Noodle.
noodle and
2
a gate
bobbies, a
belt
pool
tying it
noodle.
all together.
Yes, and there's a gate belt wound through it as well, so we would buckle it onto him. Although it was starting to look the worse for the wear, so we sort of have taken it apart a little bit because it was not holding up to function as well as we wanted. But you can see how poor his head positioning is here. And
Yeah, he still looks
improve.
like he's like in hip extension.
yeah, we were just like, I really don't know why his mom took this picture of all pictures to have taken. We were like, she sent me a bunch. This was a terrible one. I was like, thanks.
And tell us about this helmet.
Okay, so this is that Way Fun one Fay, I don't know, what are Amazon. This is the one. It has oh, I don't know that you can see the back of it in any of these. There's these pieces Velcro on the top pieces, and then there's a Velcro adjustment in the back, so you can make it pretty small circumference. Like the patient I eval'd last week, it didn't say microcephaly, but, and I didn't actually read that about this kid, that kid's genetic disorder, but when I put the helmet, grabbed an extra small helmet, I said, I think we have some microcephaly as part of this. So this child in the picture here, he's not so microcephaly, so for him, it's at the end of the Velcro. So it gives a few inches of adjustment, at least I would say probably 2-inch adjustment with the Velcro. And we had him sign, the family signed waivers that we'd be using an alternative helmet. He actually has just moved. I saw him from February 2022 till the end of May 2023. We spent the first about 7-8 months not using the horse at all, not using live horses, because at any moment in time, his head would flop forward, flop into full extension, he had full flexion, full extension with no control. And I said to his mom, and then when his aunt came to the session, I said, I cannot put him on a horse until I see a little bit of head control, some stopping of that full flexion, full extension, because fine, while we're walking, I may be able to support his head. But if there's an emergency and I have to grab this kid around the torso and pull him off the horse, am I going to accidentally injure him if he has no control? So we spent months. The family agreed, they're coming for therapy. They're coming for therapy. For what I can do as a therapist, if we can get on a horse, great, but they were willing to come for therapy. So we used TheraPlate, which is a whole body vibration. I used eStim in this picture. I have 2 eStim units on him here. I have one on his hands, and we're working on hand and grip, holding onto the handle of the surcingle. And I have a second set. You can see there's like a wire between my thigh and his thigh. That's from the second set. That one was on his abdominals because he had a ton of extension. There were no abs. He did everything with trunk extension, anterior pelvic tilt and extension, lengthened abdominals. They were doing nothing for him. So we use eStim on the abs every session. And then we varied what else we used with it. So here I was doing hands. Sometimes
So
it depended on how
interesting
many.
that you're using it on the hands, obviously not really muscles per se. Are you doing this more for vibration and sensory awareness, or
Oh, no.
what were you doing here?
So Carol, we've talked, I've taken this eStim course and by Susan Hastings, and she's doing it into using the palm of the hand and getting hand closing and opening, we started getting some finger isolation. I wished I was an OT, but the OTs were at school.
But
His
you're
mom would come in and say,
stimulating the tendons, not the muscle
yeah,
belly.
yep, and
Interesting.
it was working.
Huh.
Like the OTs kept talking, in school were saying how much they felt like his hands were improving.
Yeah. Well, Susan Hastings seems amazing, and I would love to take a course with her too. So that, that we need to have you present just on that one time.
Yeah.
Yeah.
And then
it was
let
quite
me ask
amazing.
you about the vibration plate that you had him on. What position did you have him in when he was on the plate?
So he loved to lie supine on it.
Okay.
That was like his favorite. He just wanted to lay there and loved it. So we did some supine, but then we were working on supine to sit and trying to get flexion as opposed to coming to sit via extension. Because what he really wanted to do was push his belly upward and leave his head in an extension and extend his way upward as opposed to flexing his way upward. So we worked a lot on flexion to come forward as opposed to extension. We also sat on the edge of it so that we could try to work on getting his legs into a more neutral position. And then I never got to see his x-rays. His mom said the orthopedic surgeon was not, said, doesn't really have scoliosis. Yeah, okay, but he looked curved to me some. So we did a lot of using like breath work to try to expand on the concave side. So I would stabilize the convex side, and he was nonverbal, but he could understand a lot. His comprehension was very strong. So I would have him breathe in and out with me to expand that concave side while I stabilized the convex side. And then we did that on the horse as well. So those were sort of some of our pre work, whether it was pre getting onto Elvis, our equisizer, or pre getting onto a horse.
And let me
So I
ask
did
you
this-
one other thing. What kind of padding do you have on that equisizer? Because those things are as uncomfortable as can be.
So there we have, I think there's an English pad with a yoga pad underneath it. We had some cut up yoga pads to add some extra foam.
Okay.
And then when I put him on a horse, here's a video. I don't know if this is the better video or not. This might not be the good one. So on the horse, we have a Western pad, that one-handled surcingle. Oh, there goes his head a little bit, but now he can correct it. I don't know if you saw it, like his head tipped back, but he
Yes,
brought it
yeah.
forward again.
Mhm.
Whereas when we started, he couldn't bring it forward. He went back, he was back and done.
Right.
That was it. I had to lift his head for him. Okay, so yeah, we're using a Western pad, a yoga pad, and then a very thin English pad, because no one wants to sit on a yoga pad. They get sticky in the Georgia heat. But that one of the ways we give some extra padding that was cheap for the barn to acquire a bunch of them when we felt like we needed a little extra padding. This horse is pretty bony. I only sat on him once because I'm probably above his weight limit. And I remember him being a fairly bony horse. I used the one-handled surcingle because I did want him working on grip, and he enjoyed working on grip. I give him stirrups because he really wants to have that anterior pelvic tilt. And so by bringing his knees upward, it helped him keep and maintain a little bit more of a neutral pelvis. In this, the double boppy pillows, we're trying instead to use the My Breast Friend, but it was a little too low for, he has a relatively, he's, I don't know, 11 at this point, 11 and a half. he was long, long. And so he needed a little more support. So we put a boppy pillow on top of it. And I used webbing and buckles to hold it together. So I didn't worry about it falling apart. My horse is 13-ish hands tall here and grades quite well. Like they view him as one of the slower horses, but he gives decent amount of input actually. At this time, we did have one shorter horse on property who I thought about using, but her gait was too choppy. And it was like too much amplitude for him to handle on his head.
Mm-hmm. The position
So-
of your arms is very similar to what I was talking about with the use of the physio roll.
Yeah,
that-
and that's where
thing
my best friend worked great.
Yeah, yeah. The idea of having something compressing into the lumbar spine so that you are helping to keep that anterior tilt, like you said, and the lumbar extension. Now, the thing I have tended to find with stirrups attached to a surcingle is that it's hard to keep those lower legs back in the like desired alignment. They tend to kind of shift forward. Did you find that with him? I see where the stirrups are attached.
I say the position he's in there, wherever we positioned, these did not tend to move much. I think I just got lucky, more than anything with that, because I've had other people where you're like, their legs are sort of going all over the place. But because he was tended to be so anterior and he would really, like his pelvis really wanted to rock anterior by bringing, even though it's not good riding position, but I was working on getting him to feel a little bit more of a neutral pelvis. And by bringing the femur up, he tipped into more neutral. So.
Okay. Michelle, Karen Gardner just added quite a chat input to everybody about using the headmaster collar for patients that need to practice head control within a small range. You can see a picture on Amazon. It has a firm frame that you can change that supports the jawline and is based down on the collarbone. There's a soft strap across the back of the neck, but nothing touches the front of the neck. By adjusting the frame so that he can lower his head an inch or so and then come in contact with the support frame, he can practice what we call head push-ups. Gradually, hold on, patients who have potential for head control can practice over a greater range. It also makes a difference to cue him to stabilize his head before the horse moves and before the horse stops, so he can practice some feedback feed forward. Preparatory for movement. Wow, that sounds awesome.
I'm gonna look that one up.
Want to tell us more about this headmaster collar? Where do you get it? You get that on Amazon.
You can now. I got mine originally from Headmaster, but there's a frame that is adjustable. You can decide how it goes just under the jaw, not under does not cover the throat, just the jaw. And you can adjust the tilt, and then it comes down the side of the neck and lays onto the collarbone. And then it has a soft strap that holds it on that goes beneath the helmet. And you can tilt this, what comes in contact with the jawline, what angle you want. So if part of it is with the weight of their head, a lot of times they can control here, but once they pass that spot of too much weight, then they lose it. So if we could gain a little head control here, touch up, head push-ups, then you can work on that. And the therapist can adjust what level it goes under the jaw. You have to see it and think about it. I mean, I would be glad to talk with, I meant for that note to go like later. I didn't mean to disrupt anything. But I have used it very successfully for people who did not have head control. Of course,
I just looked it up.
positioning.
That sounds great.
Yeah, positioning, movements, all that helps, but sometimes you need to give them something place to protect them so that it's not this complete loss of
Yeah.
control.
What with this kid, what I found in the beginning, we moved 30 seconds and then we
Yeah.
stopped and took a break. And he
Yeah.
could click to tell the horse to go.
Mhm.
So I'd say, okay, we're going to take a break. When you're ready, you're going to lift your head and click. And he would. And by the end, we got up to about 7 minutes. But
Oh, wow. That's
yeah.
excellent.
That is
And
amazing.
functionally, during this time, they were looking at different communication devices. And prior to this, he used a switch on his belly and then a second switch where he tilted, I think, left. But he couldn't do a full head control because he didn't have enough head control.
Mhm.
And during this time, they switched his communication device to one that was purely head control device.
Mhm.
Very
Yeah.
So, which
Wow.
answered my question functionally of this is helping.
Yeah.
We're seeing that
kidding.
functional
Right.
change, you know. I always tell parents, I don't really care how well your kid can sit on a horse. I'm looking at how well can they do X, Y, or Z in their life.
Mm-hmm. Well, that's a pretty
So,
functional task that you helped him achieve. You know,
yeah.
communication, pretty important.
Yeah, I mean, did you say he had CVI?
Mm-hmm.
I was gonna say, because even with that increased head control, an eye gaze could have been, an option for him at that point, depending on his level of CVI.
Yeah, I think the thought was that an eye gaze control device was not going to be, because I read his prior communication device report, and that basic at that time, which was a few years ago, but they viewed him as not particularly having much functional vision. So we also saw we had a really good team. I had consistent horse leaders, one for the first 6 months and another for the second 6 months. And I had a consistent sidewalker who came on, other than days, times that she could not make it, but she was there every session, including from before we were using the horses. So I had these volunteers during the sessions when we are not using a horse. So they got to know him and how he communicated and how he interacted and what I was looking for and doing, so they could really serve as extra hands for me.
And Michelle,
And
I think that you've hit on a really important note there, that it's the team, and it's,
Yeah.
It's how that team is working together. And if you're working at a facility where you've got a different volunteer showing up every week to help you with a child like this, yeah, that you're not going to have that consistency. So that's very, very good point.
right. And I can actually see, I'm looking at the outfit of the person in this video. This was actually not his normal sidewalker. I believe, if I'm correct, I believe it was the leader from the first 6 months that I was seeing him, because so then they were trying to pick the same few people amongst the same few people who really knew him, knew me, knew what we were looking for, so that I'm getting more skilled hands, not just random hands showing up.
Well, and I just have a comment about the visual impairment, and this is a comment I absolutely do not know. But in thinking about how the developing brain develops visual control, taking in images, being able to stabilize their gaze through a stable body position, you just wonder what will happen as these young people are able to be more stable in relationship to visual objects and be able to react to them, and how their brain might be affected by that, and hopefully their vision be able to improve. Because you can imagine with a cortical visual impairment and not being able to effectively visually relate to the environment, they're not stimulated to have those, visual experiences. So
Yeah.
I don't know what might happen. It might be very interesting to follow these people over time and see what happens with their vision.
I can answer some of that. My 9-year-old has CVI.
Mhm,
He has gone from a stage, so there's kind of 3 stages.
mhm.
It's a scale of like 1 to 10 basically. He went from a 2 plus. He is now about a 6 plus. He probably won't get much better than that, but that 5 to 7 range is integrating vision with function. So being able to see something, reach for it. It's
Right,
functional
right.
vision. So he is
Yeah.
functional now. And a lot of what they talk about is when you are using your vision, your eyes are his are functional. His eyes are normal. He can see everything we can see, but it takes a lot of concentration, and it's basically to work on your vision, it has to be the sole focus. So if you are doing things like physical therapy or speech therapy, or you're sitting on a therapy ball versus your wheelchair that's supportive, your visual reactions are going to be much, much different. So having a nice, stable, supported trunk, their vision, their use of their functional vision is improved, because they're able to isolate and really focus on that.
Right.
More movement usually causes them to use less of their vision. So what you may see is he may not use much of his vision with therapy or with the horse. So you'll have to be a little more creative to work on things that get his attention. But the results afterwards of the increased strength and the increased stability will help him be able to use his vision more functionally. Does
Right.
that make sense?
Oh, yeah. Yeah. No, I've seen the improvements myself over time. But just
Yeah,
thinking
so-
about it in general, you never know how much it's going to affect them, and really posture, you need to reflect that on what his goals might be.
Yeah,
Potential.
his mom was surprised one time because the volunteer, it was pretty early when we started using the horse. She asked him, we had him helping hold a ring, and we were helping him reach to put it onto something. And the volunteer, he turned away because that's typically, as he's accomplishing a more difficult motor task, he tends to use less vision because he's concentrating on the motor, pulling in some reflexes and different things. The volunteer said, no, you need to look at it. She doesn't know the details of his vision. And so he turned his head, turned and looked and reached, and mom was like shocked. She's like, did he, she saw it from a distance. She's like, did he actually look? I'm like, because he loved this volunteer. He was so motivated by the volunteer. She came, just about every week, and she interacted with him and she spoke with him. And because he was so excited for it, he also loved, there was another kid often in the arena at the time who would sing sometimes. And so now we started doing more interactive between, they were doing an OT session, we were doing a PT session, but we would start doing like red light, green light. And he loved when the other kid would sing sometimes. So they would try to communicate with each other. And the other child, one of the tests, I think, was obviously drawing a picture of a person or something. So the OT had him doing that while Andrew was, my patient was giving like the cue, the click to say, go to the horse. And so we really tried to build in interaction in the sessions as well, which was so motivating for both of the kids. And that also, it was those last few sessions, I really saw an improvement, again, in that head control. So I think there were 2 pieces. One, what we were doing physically, and then the motivation of somebody else. And then another set, we have the kid who sang came every other week. And on the alternative weeks, the last month or so, was another kid who was pretty severely involved like this. And I would say to him, I need you to show the other therapist, how you sit so tall and how we help you, because we're teaching another therapist and another patient in the arena how to sit tall and pick his head up. And that was also, he loved, because the other kid was a lot younger, loved modeling. So again, super motivating, because how often does he get to model, physical skill? So, and unfortunately, if anyone knows a therapist down in the St. Simons area of Georgia, St. Simons Island of Georgia, or Brunswick, Georgia, because that's where they've moved, and they have not been able to find anyone there. Mom is desperately looking for great therapist. So if anyone knows of anyone,
Where are you at
Yes.
again?
I'm in Atlanta.
Oh, okay.
Yeah, so they're a little too far.
Where is, remind me where St. Simon's Island is. Where is that? North or
East-
south? Well,
East
yeah,
Coast
East Coast, but is it north or south? Is
South,
it
because I
close to
think,
the Florida border?
yes,
So
Yeah.
there are places in Jacksonville and Orange Park.
so I don't know whether Jacksonville itself is going to end up being,
Too far.
like, I'll have to, ask the family if Jacksonville itself is too far. Can I share something, a different client, something separate? Carol, the parents had signed photo permissions for work, but you can't see his face in this picture. I just want to show a picture of a back. It's a little bit of a funny thing. Let me find it. See all my pictures here. Album search T. Oh, that's not going to be a good idea. Shoot, I just pulled it up because I wanted to show. It was pretty striking. Oh, there it is. So you can't see his face. This was at the beginning of a session with a kid. You can see pretty significant scoliosis as we were talking about, like, different positions and things
And
that we
how-
used.
How old is this child?
Oh, 9-ish, that picture.
And this is
I'm not-
this is all neuro related. There's not a
Yeah.
skeletal deformity causing the scoliosis.
On
Like a
he's had x-rays, so I
hemivertebra.
don't think it's
Okay.
you
And was it
the spine-
functional? Was it a functional
Some-
scoliosis or a structural scoliosis?
combo of both.
Okay.
Combo of both. Definitely a functional component. There was some structural that they were watching. When I met this kid, the parents told me he could not rotate his head or turn to the right. I said,
Yeah,
okay,
I guess I would have a hard time too. if I was in
right.
that
Well, he
position.
has a shunt, and that's what they blamed it on.
Oh,
And I was like,
but the shunt normally goes along the right side.
correct. And it's flexible. So, but
Yeah.
it was day one when I met the parents, so I was not going to start arguing about that. They believe that very strongly. In one session, and I'd known him for a while. I've been working with him for a long time. We started doing some side lying on the horse, and this is the end of that
Mhm.
same session.
Very cool. Megan
can
is asking
rotate
what
right.
kind of pad that is, Michelle.
So we have, the red and black is just a Western pad. And then on top of it, we call it the black hippotherapy set. It's the bottom that it came with is like a black foam. And then this is a pad that's sort of saddle shaped, but it's just, I don't know, some sort of felt, like a wool felt maybe. If I ever
Does
sat
it
on
have
it
a
without,
girth? How does it stay on?
yeah, and then the girth is attached to this part.
But it's not
Um,
something you could just go out and buy.
No, you cannot go on, and there's a handlebar that slides in and out, that you can slide in and out. I love it. I want to get a second one, and it does not exist anymore. Have not been able to find it.
Well, obviously, you did a really nice job here of getting him sitting upright and getting him turning his head and rotating to the right. in
Isn't that
this.
crazy?
Yeah, that's awesome.
His parents, upon seeing this, really bought into, we did a ton of side lying.
Mhm.
Did a ton of side lying work. And then they did it at home. They did a lot of it at home. And over the course of a year, his scoliosis on x-ray improved 5 degrees, which we all
Awesome.
know the doctors
Yeah.
generally view these kids as, when it gets bad enough, I'll operate.
Right.
So, and yeah, he was very much, it was amazing to see what positioning could do. And he also could follow directions. So I would have him do like active side bending from that side lying position. So raising against gravity.
Mhm.
But yeah,
How about planks? Could he do planks? Side planks?
I did not have him doing them. I don't know if he could. And this is before, this was a number of years ago. This is before I was using binders. On my other patient, I use an abdominal binder, which I think really helps with kids figuring out how to engage their core better. And I was not using it yet at that time, so I don't know that he could have.
So I know we're about to wrap up. Jodi has asked, don't move your picture. I just want to point something out real quick.
Okay.
Can
Hold
you
on, I'll
put
go
that
back.
back up, just because I was thinking something. Jodi has asked if she can present next time, and I'm sure nobody would say no to that. So I already said, of course. Obviously, this child has a scoliosis issue, but I don't know what his hip issues are. But when we talk about evidence-based and we talk about research, I will tell you that there's an article out there, and I had written it down, and I apologize, I have misplaced it, but I think I've referred to it in the past at previous meeting, that actually shows that with our kiddos who have a lot of tone, and that does not appear to be his case, but a lot of adductor tone, we have to be really careful about maintaining a prolonged abduction. And horse riding and hippotherapy has been found to be detrimental to the hips of some spastic, quadriplegic, very severely involved patients. And so it's just always something to be thinking about, that while we've got to be monitoring pelvic alignment and making sure that we're maintaining symmetry, because it's really easy. And we know that with all of our patients that they have a stronger side, increased, a side that's got more tone than the other. And so it's easy for them to pull into an asymmetrical position, and we can actually be creating subluxations and potential dislocations, and if nothing else, causing some severe arthritis of the hip joint. So it is something to use great caution with as we're choosing straddle sit positions. And so I know previously, maybe Brianne, with you, was with the child with a lot of tone, and I think you had said that side sitting was one of the positions that you were in.
Yeah, that's what we had to start with, because he did not have enough abduction to even get near the withers, like with his knees up high. He couldn't even abduct that high.
So a modified side sit can be a fantastic position, and may for some of our patients be as far as we get, so I just wanted to kind of point that out, that there is evidence to say that there can be some damage from prolonged hip abduction, and I just wanted to point that out today.
What do they, I'm curious about that article, Carol, if you could send me some of that information, because
how
much of that can they determine is it from the equine movement and hip abduction, or is it just the positioning?
It was primarily the hip abduction. It was prolonged hip abduction.
Okay, so like in a stander or any other position with some abduction to it.
I don't know about a stander per se, because that's a very different kind of, that's weight bearing. I think that's a very different kind of hip abduction than just a prolonged stretch. I think of it like sitting them on a bolster or sitting them on, something where you're really maintaining the position. But I don't think stander, because stander should be exactly the opposite. That should not be.
Well, that's why I was kind of curious, because a lot of my positioning for my son, he's 9 and has cerebral palsy, and we're trying to avoid any hip issues and spine issues. And he's 9 and he has hardly any. He's doing really well, but never heard from his orthopedic or anything about that. So I'm really curious about that, because
I think these were for the really involved kiddos.
Carol, I wonder how old was that article in terms of the last 10 years or so? I mean, I've been practicing for over 20. I know 20 years ago, there was some talk about getting kids into abduction for standing and things, but I know for sure now we really are much more aware that when we're getting kids into standers and things, to be putting them into hip abduction to improve that socket.
No,
and that depth of the socket.
absolutely. But this was for the really tight, spastic hip, hip adductors, maintaining them into an abducted position.
And this kid
it was 2010 was this particular article.
Right. So, but I sort of wonder if some of those kids now, if it's partially because they were never positioned in abduction to, like,
or the way that they were being positioned, but they were very
Right.
specific with regards to the riding and to the
Got it.
hippotherapy.
This kid actually does have some tone issues.
And I will say, I see a lot of kiddos who look pretty bad sitting
Yeah.
astride a horse. I'm just saying, be careful. That's a take home. Look for symmetry.
This particular child here he was like the perfect example of responding beautifully to everything we did. Did the side lying and working on that scoliosis,
awesome.
and he
Yeah.
straightened up. He was on clearly a very tiny pony here. And his steps were super, super fast and super, super short and super choppy. Guess what? He walked too. Super short, super fast, super choppy. I was like, I need to change this. We put him onto a horse in one session. Longer steps, slower, smoother. I was like, oh, come on. Like, why didn't I change that earlier? But he was the classic example. And he was a kid who used to use his wheelchair primarily. And then they went on vacation. It took time, but at the end of it, went on vacation, and mom says to me, just so you know, we left his wheelchair home. I'm like, you flew to Florida. What do you mean you left his wheelchair at home? Just a walker. I'm like,
Wow.
you went through Hartsfield Jackson, like in Atlanta, like the biggest airport, like with just his walker. It's like, yeah. There you go. And his walker had like a little seat that could drop down and he could sit on it when he needed. But doing what we did here and improving that gait piece, those steps, changed this kid's life at that, of course, I've since lost contact as they've, pandemic and all that fun stuff. But yeah, really, really changed it. He was a great example of what we can do.
Looks like Joanne found the article I was referring to. So she put that in the chat.
Okay.
Okay, guys, it's time to wrap up, and I'm really surprised I haven't lost the internet, because we've had a pretty good storm going here, and our internet's been pretty spotty as a result of all these storms. Thank you all so much, Brianne and Michelle. Thank you so much for your patient, sharing your patience with us, and for everybody for sharing their information. This was an amazing turnout, and it was really nice to have some of the other faculty, Joanne and Karen and Mary Helene. So, really feel very fortunate that we had everybody here. Esther, it was great to see you. And Susan, I know, has been on, but hasn't, we haven't really seen her face today. And Maria, of course, we know how early, how late, how early in the morning it is for you in Greece. Maria was reminding me of an SMA patient that she's been working with. I'm wondering, Maria, if you wouldn't like to share her next month. Jodi, you can think about it. Jodi is going to present her patient that she was planning on today. She had internet issues. Hopefully I won't be purple next time. But I'm thinking if we look to 1 month from now, we would be looking at July 17th. I know a lot of people go away in the summer, so I'm not sure. Can I just get like a hand up? Would July 17th be a good date for you? Okay, all right. So enough people saying yes, that we'll go ahead and schedule that. And we'll continue on this topic of complex patients. Please, if you have one, let me know, either email me at hippopt@aol.com or message me on Facebook Messenger, or just, put it in a comment in any of the posts we've had with regards to this, and I will get back with you. So, I know we've all had kids like this, and even if you don't have pictures, if you just want to describe, what your patient and what you did and where you got stuck,